Welcome to Therapy Cafe, the Future of Mental Health, Episode 1, Elevating Therapy, Evidence-Based Practices in Mental Health, with our guest, Linda Rosenberg. I couldn't be any more excited to launch this new iteration of the Future Mental Health podcast. Starting this season, the podcast will include the option of obtaining continuing education credits for each new episode. We'll explain more about how to obtain CEs at the end of this episode. This series is something I've wanted to do for a long time because it perfectly aligns with why we created PsychHub in the first place, to promote the use of evidence-based practices in mental health care. When I was in grad school, I primarily learned about theoretical approaches to treating mental health. I loosely knew what evidence-based interventions were, treatments that have been proven to be more effective to treat different symptoms, but I didn't know what they were or how to use them. I often think about it like chemotherapy. Not only are there different chemos for different types of cancers, but they also get better and better over time. Similarly, in mental health, we now know there are different approaches that are evidence-based on how to treat things like anxiety, which are different than how you treat eating disorders or substance use or complicated grief or any of it. PsychHub is a place where you, as a mental health practitioner, can learn cutting-edge interventions to assist with your practice. Do you know it is estimated to take 17 years from what we learn in research to be translated into practice? Our goal is to close that gap to get you the latest and best information possible that you can use in your practice right away and achieve the clinical outcomes that you and your client want. Because we know how busy you are and how much time you probably spend in front of the screen, we created this course series as a podcast so that you can listen and learn on your commute, on your run, on your walk, or whatever. This was the idea behind Therapy Cafe, and there is no better topic to introduce the series than how therapists and their clients can benefit from evidence-based practices. And no better guest to discuss this with than my good friend Linda Rosenberg, who is the Executive Director of External Relations at Columbia University's Department of Psychiatry and an expert and accomplished advocate in implementing evidence-based mental health programs. Here's to my conversation with Linda. Linda is on faculty at Columbia University's Department of Psychiatry and a senior advisor to Impactful Capital. She's a prominent figure in behavioral health. She is the former president and CEO of the National Council for Mental Wellbeing. She's expanded membership to over 3,000 organizations and has championed incredible policy initiatives. She introduced mental health first aid. She brought it to the US to over 3 million Americans. With a background as New York State's Senior Deputy Commissioner for Mental Health, Linda established diverse mental health and addiction programs. She's currently serving on numerous boards, and she specializes in recognizing business opportunities, fostering service growth, and adeptly navigating the complex policy frameworks essential for scaling, encompassing regulatory and financial considerations. That's sort of just the very beginning. And we could go into it, and we probably don't have the time to really go into it, but just those specialty things that Linda does is she'll think about what's needed in the space, how to actually implement it, but then how to get the policy to support it, work both sides, and that's when magic happens. And Linda is one of these that doesn't even really need an intro. However, she'll never, ever truly know how many lives that she has touched. So we're super grateful to have her here and to really be able to have a conversation to frame out this whole podcast series, which is interviewing several different clinicians who have real expertise and evidence-based practice on different areas. So thank you. Thank you, Linda, for being here for us.
Well, thank you, Marjorie. I mean, I could give an overview of your bio, which is amazingly impressive. And you're not only, a real icon in the field, you're also a very special friend. So I'm delighted to be here.
Thank you. So nothing better for everyone than to be able to listen to, two good friends talk about some of our topics that we love so much. So,
Yeah.
we've been in this space for quite a while. We've seen quite a bit happen over time. I will say that just to kind of like get started in this, sometimes you're going to hear us say EBPs. That stands for evidence-based practice. Sometimes you're going to hear some people call it EBI, evidence-based interventions, therapeutical interventions. By the way, these things have been in the medical health system for forever, right? What is the evidence base to treat this kind of cancer, this kind of heart disease, or this kind of diabetes? We're just getting started in it in behavioral health, but it's real. And I always use the expression, you wouldn't go to a cardiologist for a broken foot, but that's kind of how we do mental health. So that's what I think is, the most important piece of just framing the why of this. But Linda, let's just
Yeah.
start from the beginning. Like, what is an evidence-based intervention?
It's not only what it is, but I really can't think of a more important topic. And I've been at it for 30 years with not that much success. So let me begin by saying that. Hopefully, we'll talk in more detail, but I really did want to start that. And I think, getting effective treatment, and that's what evidence-based treatments are, they're really, we shouldn't expect anything else. As you just said, we don't expect it for any other condition. So I think when you say what are evidence-based treatments, there are treatments that have been studied in randomized control trials, have expert consensus on which they are, have case studies over the years, and in all those cases, the outcomes have been better and people have improved. And that's an evidence-based treatment. When I got started focusing on evidence-based treatment, it was really the mid-90s. I had come from spending 20 years operating clinical services, including operating a state psychiatric hospital. And I got to go to Albany as the senior deputy commissioner. And I knew now I would be in a position to try and make or help make policy and fund it. And I knew I would have that influence. And I brought with me the 20 years of all the suffering I had seen,
Oh,
not
wow.
only among patients, Marjorie, but around their families and friends. So their entire people in their lives were struggling, and so many sad stories. And then 6 years ago, I had my own experience, and you just mentioned cardiology. I needed a cardiac bypass surgery. And what I realized in going through that process, I had the surgery at Columbia. I was not on faculty at the time, but if I would have been at any other major hospital or even small community hospital, I would have gotten the same treatment. That was the standard of care for the arterial blockages I had that couldn't be treated with a stent and needed surgery. And when I thought about that, I thought about, well, what if I had treatment-resistant depression, depression
Right.
that wasn't going away? Well, I would get something different depending upon who I saw and where I lived. The other thing was my surgery was covered by insurance. There wasn't any back and forth about were they going to cover my surgery. They didn't need a special grant to do it. It wasn't a pilot project. And no one asked me, well, will you save overall healthcare costs if we give Linda Rosenberg bypass surgery? So
Right.
it really took that, what I had been caring about since the 90s and really brought it home personally to me.
Thank you for sharing that story. What a great frame of all of this, because you're right. It's the protocol of exactly what to do. And we're lucky that that surgery was successful and that you're
I'm
still
lucky.
here, but it is true. And I mean, I guess part of it is, how does something become evidence-based? Like, how do we get there?
Yeah. So we get there through research. Research continues to be important in every field of medicine, including mental health and addictions, because what is the evidence today may in fact change in the future, but it does have to go through that process of randomized trials, of consensus, of case studies, and then one can say, listen, there is evidence. And when we look at the outcomes for people who are treated with this evidence-based protocol, the outcome is better. And that's the process we really have to go through. And success, how do you measure success? Well, improvement of the condition. I'm fine 6 years later. That's how success is measured. Other people may still have other lingering symptoms that need ongoing treatment. Same thing with mental health. But whatever the intervention was, the improvement was there and was measured.
So I would imagine, Linda, that the process of something becoming evidence-based, right? That's been around a while, can
Yeah.
take a while.
Oh,
What
yeah.
about this kind of notion of evidence-based informed, right? Like it's not quite, have you heard that? That's sort of like this
Oh,
new term
yes.
right
Yes.
now where it's like it's not
Yeah.
quite, uh full
I
blown.
think that's very nice, but it shouldn't be mistaken for evidence-based. And what I would like to see is every clinician, that means social workers, psychologists, psychiatrists, all be skilled in the evidence-based practices, and then spend some of their time maybe adapting or even introducing new interventions, realizing that it isn't the evidence base right now, and sharing that with patients so that we have transparency. I mean, there is nothing wrong with being informed. I think the other thing is, if you don't have a relationship with the patient, it doesn't matter what you do. Evidence-based practices won't help if you haven't established a relationship, not only with the patient, but if the patient agrees with their family and loved ones. So everyone's on the same page. So I would say all that is good and well, but you need basic skills.
Okay, so that's good to know. So today and for this whole series, we're really going to be talking about evidence-based interventions. So why should clinicians use it? What does the evidence say about evidence-based practice?
The patients get better. Just, when you talked earlier and introduced the series, what you said was it is a better healthcare system, and we have many systems that operates based upon the evidence because their patients do better. They improve in whatever the distress was that they brought to their provider.
Okay, so there we go. I hope that we've now helped our listeners know why this is important. What are some examples of evidence-based treatment for all
Yeah.
mental health and substance use? What are some
Yes, so
examples?
there are many. So there is cognitive behavioral therapy, often referred to as CBT for depression, DBT, dialectical behavioral therapy, which is originally focused on people with borderline personality disorders. ECT, which gets a very bad name, right? But when you go back to that old movie, One Flew Over the Cuckoo's Nest.
Right.
But for middle-aged people who have treatment that isn't responding to verbal therapies or medication, ECT, electrical convulsive therapy, is very effective. So that's another evidence-based intervention. For people with schizophrenia, assertive community treatment, highly effective. That's mobile treatment, bringing the treatment to someone whose illness causes them to perhaps often be more disorganized than they would like, to have more trouble dealing with the tasks of daily living. So ACT is another one. For people with addictions, medication-assisted treatment. Everyone hears about Suboxone now. The other one that continues to be highly effective is methadone. For youth, particularly youth who are in danger of being in trouble with the juvenile justice system, multisystemic therapy. And for prevention, there is the Nurse Family Partnership Program, highly effective working with pregnant young moms for the first 2 years of their baby's life and really helping the whole family get on a stable footing, which then has better outcomes for that child. So those are just some examples of evidence-based treatments that should be available to everyone today.
It's amazing how you can just rattle that off. I mean, you really know and understand this, all of this. Do you see this value that, for where we are now, where everybody's now, stigma's kind of been reduced quite a bit around seeking mental health care. It's very commonplace to get it. Do you feel like if we can get our providers to, really start thinking about evidence-based practice, using it, it'll make a difference? Like, I guess what I'm trying to ask is, are you inspired?
I am. I'm inspired, and we can talk a little bit about some of the things that are inspiring me. I mentioned earlier getting involved in this in the mid 90s when I went to Albany as the senior deputy commissioner. And at that time, it was based upon all the suffering I had seen and the reading. The other thing is we have to be avid learners our whole life in every industry, right? So
Right.
you've got to keep reading. So I knew there were effective treatments, but I knew people weren't getting them. And I think that, that started this journey that we've been on, and a lot of money has been spent at the federal level and state levels trying to get adoption of evidence-based practices. So once I was in Albany, that became our mantra at the Office of Mental Health, and we called it the Winds of Change. And we went around to all of the mental health centers because we were starting in the public sector talking about what they were, why people should do them, and it became a joke. So when I came in the
Sure.
room, people started saying, well, here's the wind of change. And so it was totally not successful. But, I wasn't about to give up. As you know,
Mm-hmm.
as another very tenacious person, things, it's about timing, right? It's not only a good idea, it's what's the environment for the idea. And I think we're edging closer for evidence-based treatments to actually be a requirement, with not only incentives, but what I call punishments for not delivering them. And when you want, Marjorie, we can talk a little bit about what that looks like.
Is that like the carrot and the stick?
Yeah, I'm a big, believer. People don't like to talk about the stick, but I think sticks matter. And I think an evidence for that kind of point of view is, let's think about telehealth and telepsychiatry, right? So
Mm-hmm.
before the pandemic, every practitioner would say the patients don't like it, they don't want it, right?
Mm-hmm.
Then the pandemic came, and it meant that none of these practitioners were going to earn any money, nor were their organizations. Revenue came to a stop
Mm-hmm.
until they, and within days, started using telehealth. And the urgency was they weren't earning any money. So I think there has to be urgency. And when I talk about punishments, is that you're not going to get the same rate if you're not using evidence. And I think that will come because I think there will be regulations and legislation and policies out of the centers of Medicare and Medicaid that will expect people to be using evidence. And along with that, measuring care. That's the other thing. I'm
Yeah.
not
Yep.
interested in measuring
Yep.
you against an evidence-based treatment. I'm interested when you're working with the patient, are you measuring how they're doing with an instrument? And there's many instruments. There's the PHQ-9, the DLA-20, that you can use with the patient as your partner to say, is what we're doing helping you? And let's use an objective measure to look at that. When I go to my cardiologist, which I do every 3 months, she takes my blood pressure. Before I go, I have blood taken. She has all my numbers, and that's what we measure how I'm doing. We have to do the same thing in our part of medicine. I don't blame anyone because, Mental health, it's like the last frontier, mental health and addictions. The brain is the most complex organ. Much of it interacts with the environment and your social situation. And so it is complex. But we have to, grow and learn as we get to be a more mature science. And people, all other illnesses measure how they're doing, how their
So
patients are
true.
doing.
I'm so glad you brought up the outcome piece because what I have found, and you tell me if this is similar to you, is most therapists will say they're using evidence-based interventions, that or evidence-based practice, right? That is what most people think that they're doing. And I spent over a decade in private practice, and I thought I was using it because I didn't know, and I was treating almost everything the same because you cut, a little bit more ritualistic or habitual about how you're treating. And so that when you start layering in using the evidence-based intervention and then really collecting the outcomes and measuring those outcomes, then you have that extra step of, well, maybe you think you're using the evidence base, but it's actually not, or it is what it was a decade ago, but it's actually changed.
Yep. Yeah. No, you're totally, totally right. It's interesting. I'm involved in a project at Columbia where we're creating a lay workforce actually that is trained and supervised for up to a year in delivering short-term interpersonal therapy, safety planning for suicide risk, motivational interviewing for substance use disorders. And the other piece of that is the biggest group that is delivering treatment today is social work. And I'm a social worker, right? And that is not a hard intervention to engage schools of social work around looking at their curriculum and looking at who their field instructors are, who is supervising those students when they're out in their internships, field placements. I think we can revise that with some effort and even with some philanthropic dollars. That is not a big lift. No one that I know of is doing it, but it
Interesting.
really is something that can be done and should be done.
It makes so much sense, right? It just makes so much sense. And it's nice you have this kind of university experience now too, where you've gotten to meet these people and know these people who are also helping to kind of develop the evidence. So
Right.
I think another thing we have to think about is it fair to say that an evidence, let's just say, I'm making this up, so, this is not an exact example here, but that we say CBTI or CBT for insomnia is the most effective treatment. But what about, is that maybe the case for white males in an urban setting,
Yeah.
but
Yeah.
Black females in a rural setting, it may not be? I mean, are there any sort of types of
The caveat,
populations?
yeah, the caveat, Marjorie, that I would offer is you should at least know what is the evidence is based upon the research. And researchers, by the way, work so hard, have, Google ads, Facebook ads, trying to get, diversity among the subjects. So it's not like they don't know that that's a problem. There are lots of things I could say about academic medicine and how slowly it moves, but I cannot fault them on how hard they work, not only to have diversity, but to have people informed, to know what they're getting themselves into. There is a tremendous focus on that. But I think, again, to me, this goes back. Clinical excellence means, to me, having cultural humility. So when you're working with someone who is of a different ethnicity, a different race, a different socioeconomic status, it's your job to understand that, to ask questions, to establish a relationship based on what you do have in common. And often we have much more in common than we have different, but also understanding differences. Is it a
Right.
family that's first generation here in this country? They're going to have customs. They may be more involved with each other than those of us whose families have been here for generations. But you ask questions, you get the answers, and together you decide, well, should we try this anyway? Let's see how you do. We're going to be measuring sharing it. So I think humility and the relationship is still the foundation of your practice.
I love the notion of cultural humility. I spent many years working with the military, and I didn't come from a military background at all. And when I first got on base and started working there, all I could feel, Linda, was how much I didn't know. And in the beginning, I tried to just get as much information as possible so I could feel and sound informed when I spoke. But that just didn't quite give you all the information that you need. And by the way, each branch is different. And I was working with drill instructors. So now they were Marine Corps drill instructors. So all that to say, I found the most effective thing for me was asking them
Yeah.
to help educate me. And through that process, I then really learned that was cultural humility, right? I needed to
Right.
learn what is the military culture like, and for to have the humility to say I don't know, but that doesn't mean I don't care. So I've always loved that.
Yeah.
I've always loved that expression. But what do you what should a therapist do if someone comes to them and they need help in an area that maybe they're not experts in?
Yeah. Yeah.
How
So,
does one
so
handle
I think, first of all, we have to be
that?
honest, right? Have to admit it. You've been diagnosed with a borderline personality disorder. I'm not a DBT expert. We can go two ways. One is, I can get supervision and continue to work with you because it seems like we really connected in this first session. Or I can find someone for you who is more skilled than I am. And what that means to me, Marjorie, is you don't let that person go until you've made that connection for them. Giving somebody a telephone number is
Yeah,
not
that's
taking
such a
care
good
of them.
point.
I get so angry when I hear that.
Yeah.
Oh, I gave them 1-800, blah, blah, blah. Well, they called you. You've got to deliver something, and it may take some work on your part, but wouldn't you want someone to do that for you or your family member or your best friend? And while we were talking the military, can I give a shout out to Cone Veterans Network? You're now
Absolutely.
an expert in that area, and I'm lucky enough to be on their board. They run 25 clinics around the country for veterans and their families, and they do evidence-based treatment. So I just wanted to give them a shout out.
I love that. I love that, Chetta. And I also love the model of the Cohen Network in that they partner with different community
Yeah,
centers and
yeah,
different organizations in the different communities instead of
yeah,
building their own, kind of starting over. So
yeah,
that is great. And that is another example of evidence-based practice.
yeah, yeah.
So what are
Anyway,
there any misconceptions about evidence-based, like for
yeah,
therapists?
you know what therapists usually say. Well, this is more an art than a science. My employer doesn't care about it. My, clinic, nobody there knows evidence-based treatments. So there's always a reason, or, I don't believe the evidence, or the research was only with white men. I mean, I've heard it all. And again, I think, my heart surgeon didn't say to me, this is really an art. I'm not going to follow the usual protocol, or, the research was done on white men and you're a white woman and you're of this age and we do better with people 40. I mean, there's always reasons, but you need to be skilled in what's effective, and you especially need to be skilled before you freelance.
So here's what I'm going to share that I'm guilty of, right? Is that I think when I was in private practice, my way of delivering care was my own little hodgepodge of a little of this and a little of that, a little things I've collected along the way. And I hear people say that a lot. Well, I don't, do CBT, but I have a CBT inspired, treatment protocol, and that, or they don't even use the word protocol, but the way that I do it. How does that work? Like, would you say you do have to have fidelity to the model, or?
Yeah, I think you've got to start with fidelity. And again, if you're measuring what you're doing, and that for me is the key, you will know whether what you're doing is getting a good outcome. When you ask a therapist, how are your patients doing? They're all doing fine. And so nobody would be in the ER if that were true. I mean, no one ever says, well, I have 2 cases, I'm really struggling. They've been in the hospital, for 5 days. That is a very rare conversation. So
Uh-huh.
again, I think you want to be measuring. And if you're measuring and you're using a protocol and someone is not improving, you want to look at the diagnosis again. You want to have supervision and consultation available to you. Hopefully everyone in private practice is part of some kind of group supervision, right? Or some individual supervision where they have someone who's a mentor to them. And so I think these are all things that go into effective care.
Which I think is so great. That feels like we're not quite there yet, because the single shingle private practice, you tend to be pretty isolated. I'm hopeful that with all of these more recent, these aggregators and roll-ups of all these behavioral health kind of groups that have kind of stood up and bringing therapists under them, that will help sort of, raise the field, if you will, and give more
Yeah.
resources. But it's hard when you are by yourself in practice to
Yeah.
do it. And it isn't required for your license, and it isn't required for, continuing education. But yet it's super important. I guess another way to look at it is, you brought up outcomes and measurement-based care and collecting that, which again, when I was in private practice, I didn't do that. And now, I couldn't imagine not doing that. But I guess another way to look at it is that part of it is you're measuring the care for that client, right?
Yeah.
But maybe it's also another way to look at this is you're measuring it for you. So you are looking at an aggregate of measuring to really look at, wait, how this is how, anxiety people are coming in presenting with anxiety, and I'm not treating anxiety as effective as. So is there
Yes, and there's another piece to that, Marjorie, that I'm very optimistic about, which is also, I think, frightening in the bigger sense, and that is all of this is going to become transparent. So AI, and I know there are lots of fears related to it, but I am always an optimist, right? So I always look at the glass half full, is going to make sessions that go on behind closed doors visible. They are going to be watched, and you're going to actually be directed, right? There's going to be decision supports built in, and all of this will be part of your electronic health records.
Wow.
I'm also on the board of an electronic health record company, NetSmart, and they have expanded and are building in AI tools every day to make that record not only a record of what was done, but also of what should be done and can be done. So I think that's going to be very different. One of the things is when you have surgery, right, like I did, there's lots of people in the operating room. And so you're also being watched. Therapy is done usually behind a closed door or one-to-one on a screen like this, right? AI takes that in a whole different direction. And it also makes it much easier to benchmark, and really accounting also for the kinds of patients people have, to benchmark therapists against each other. That
Right.
will become increasingly transparent. So I think even if you don't want to do this because it's annoying, you have to be thinking about doing it because you're going to be judged in ways you haven't been in the past.
So is that daunting to therapists? I mean,
Very, very daunting. It's very daunting. And, we have a therapist shortage, actually, or at least we have a therapist shortage, I think, in part because we don't give effective treatment. And so people are, staying longer or always coming back or just complaining and not doing well. But we definitely have a shortage because we've gotten what we want. People talk about it now. If you talk, I have a
right.
12-year-old granddaughter, they're all talking about their anxiety, their depression. I
Exactly.
mean, it's totally out in the open. And so people are seeking treatment, and that has created a problem. But I think the transparency is going to then make it, make this change really very personal to all therapists, that you better practice on the evidence because it's going to be transparent.
It is a sign of change in time. And I think the way we have to look at it is that, no one expects us to be perfect and no one expects us to know exactly what to do. These are really hard, unique situations. Everybody comes into something with a unique lens.
Yeah.
And it's really looking at what's the best, and plus both the therapist and the client, right? The client might be more apprehensive for treatment. They might be, over pathologized. I mean, it could be the whole gamut. And so, there is obviously that individual piece to it, but this is more about, what it is. Having someone in therapy for 3 years still talking about things in the past or from high school or middle school, is that helping anybody, right? So I think
It's a luxury in a way. People still go into psychoanalysis, right? But that's a luxury. Most people need to get to their lives, right? And what they want is to have I think it's the old psych rehab. What is it? A good life, someone to love, and a place to live. That's what, people want. And so they want treatment that moves them along that path.
yeah, it's interesting because when we started Psych Hub, the whole notion of it was how do we train providers in evidence-based practice and really have them act more as specialists? Because then, everybody, like I said earlier, everyone wins. But when we went through our strategic plan, we learned, well, you really have to inform consumers at the same time.
Yes.
And so we did a whole bunch of consumer trainings and we partner with YouTube and all of that. And it's almost as though the consumer part has caught on faster than the provider part. And so we now have consumers saying, I want DBT for
Right.
this, for that.
That's right.
And so have what you've seen, um, is that an issue now where we have consumers asking, and why is it that it's taking, or do you think that it's taking longer for the
Because
clinicians, the
there hasn't
providers?
been urgency. I mean,
Mhm.
treatment isn't transparent, it's not measured. And employers, by the way, who for most people are paying the cost of their insurance, right, are not demanding it of the insurance companies. So, there's a movement called the Path Forward, that's been around now probably maybe for almost 10 years, that is working with employers to get them educated as to what the insurance companies that are the intermediary between them and their employees, what they should have available for their employees. So I think all of these initiatives, right, the transparency through AI, the urgency around rewards and punishments. The other thing is we now have collaborative care, which is, short-term psychotherapy, and medication in primary care. And in that model, measurement-based care is an integral part of it. So that is something else that's new. And sometimes it's easier to do something new than to change old habits.
Mhm. It's funny you'd say that because it's easier, but yet people sometimes are so resistant to changing habits, right? I mean,
Oh,
it's
yes.
just
That's
so.
why there has to be urgency. That's why it
Mhm.
has to be, there's now transparency, there's now rewards and punishments, it's now regulation through CMS. Those are the things that will move this agenda.
Yeah. Have you found that in larger clinics, or that they are using evidence-based more, or what
I
about,
think they're using it more than individual practitioners, believe it or
yeah,
not.
that's what I was curious about.
I think certainly I'm also on the board of something called Centerstone, which operates in multiple states, also a not-for-profit. David Guth is the CEO. They are amazing in terms of their use of evidence-based treatments. Now, they have the scope and the scale to be able to do that. They're also working with avatars. They're doing lots of very exciting things. So there are, there are always pockets of excellence, and and in the public sector, Medicaid has increased its rates. Money has gone to states under the Recovery Act, under the Infrastructure Act, under the gun bill, and it's really been used to enhance community-based treatment in almost every state in the public sector, particularly, in the Medicaid domain. So I do see them working on evidence-based treatments more than I see individual practitioners who really don't work for anybody. They work for themselves, right? And that's harder to influence, I think, Marjorie.
Yeah, first of all, we love Centerstone too. We've had David Guth on the show before,
Oh,
so
good.
he's great. And you are right. It's interesting. I was gonna ask you as you were talking, and you sort of already kind of alluded to it, but is there a difference between Medicaid, Medicare, and commercial? Whether or not where we're seeing evidence-based get rolled out more.
Yeah, I think Medicaid, most of all, and also because of the bully pulpit of SAMHSA, state mental health authorities. I mean, they often, things get diluted through politics and different people who can't give up, something they've decided they've been trained in or they love. But I think there's been a real effort in all of those areas. I think commercial, again, the path forward is trying to work with employers who are working with insurance companies. I think the other issue we have is 50% or near 50% of practitioners, social workers, psychologists, nurse practitioners, psychiatrists, all are taking only cash up front. I compared it to plastic surgery. That is not true in other parts of medicine. It's
Right.
highly unusual.
Right.
And then you're left to chase the insurance yourself. That's a problem I don't have a solution for right now. I hope someone's working on it. But I think about it a lot. I think about it a lot because in a university like Columbia and other universities, the faculty practices, often don't take insurance, or if they do, it's only one specific insurance company, and you're paying cash up front. So to get the best care is very expensive. I have a grandson who has some special needs, and to get a neuropsychological done, and you want to, the school is willing, they have to pay for it if it's, a special education plan. It can take a year. Or you can pay $8,000 to $10,000 privately. Well, how many
Oh,
families can afford that,
ooh,
right? Yeah.
right. Wow.
So I think we also have this, tiered system, just like people who are rich live 13 years longer than the poorest people. People who are rich can get the best care. They don't often, though. So, not to say they always do, because they don't, but they can.
Hmm.
And as they get more educated, they will. But what about the rest of us, particularly those in the middle? Not people on Medicaid where we're putting a lot of effort in, but all the people commercially insured.
Yeah, which is a lot, right? I believe now it's a quarter of the country is on Medicaid.
Yeah,
So that leaves, a good
yeah,
75% that
yeah.
are not. And so the change is coming. It may not be fast. Change is coming. It could be AI that makes it go faster. It could be that, as time goes on, there'll be fewer and fewer individual practitioners because the migrating over to these roll-ups is a little bit more it can be pretty beneficial for a sole proprietor practitioner because they maybe use their telehealth platform. They fill their
Exactly.
appointments a lot of times. They,
Yep,
do all of that. And they are negotiating bigger contracts with the payer. So
exactly.
therefore they could
Yep,
ask for more.
yep.
Uh, so I would like to ask a question and then I'll say my bias. My question would be for our therapists and practitioners where they could go to get resources on evidence-based practice, and I will do the
Psych Hub.
self-disclosure and say
Psych
that,
Hub. They can go to Psych Hub. Marjorie, Psych Hub is a brilliant concept, right? And you're doing amazing work. So people, the problem is we have so much noise, so much information coming at us. How do we ensure that everybody knows Psych Hub exists and it's there for the taking?
Thank you. I very much, I appreciate that. And, you know, I mean, obviously, you know, I co-founded it with Patrick Kennedy, but the
Another
impetus,
hero.
I would agree. I totally agree. But the impetus of doing this is that I didn't know where to go. I didn't know how to find things. Now, we also don't have everything. So I think, you know, and we don't go as deep as some places that just might train on a specific area. I think the most important thing is, I mean, and we try to make our super engaging because people just, they need to stay engaged. We, you know, and there needs to be ongoing learning and all that, which we've done. But all that to say, if there's something else that you're looking for, I think this idea of just what coming from your Columbia lens and all your years, what should people be looking for when they're, you know, trying to decide how to get trained or where to get trained? Are there certain things that you would say, make sure that you're
That's very interesting. You know, there's so many motivations. And you're talking about postgraduate training. I'm
yeah,
assuming you're not talking about should I be a social worker or a
right.
psychologist, postgraduate training. You know, I think, you know, Psych Hub #1, obviously. And after that, you know, you've got to become educated. You have to Google things. You've got to read things. You've got to talk to family, friends, and colleagues. You know, you have to do the legwork. Nothing, there's a lot out there and you've got to
Yeah.
sift through it. And I don't know, maybe Chat GBT can sift through it for you. I don't know. I've not tried.
I know it's not, you know, in so many ways it's great. And I have used it quite a bit. It's not so great in this area because it's
Yeah,
just not something that it's learned. And so I have seen a
exactly.
lot of misinformation on there, and hopefully that will get better.
Exactly.
So before we end this and I let you go, I want to summarize and make sure that I captured and we captured all of the things that we talked today. So tell us the role of evidence-based interventions and the critical importance for substance use and mental health disorders.
Well, they're the standards of care. And the thing we didn't mention, you know, Marjorie, we talked about policies that would, you know, mandate evidence-based interventions and measurement-based care. We didn't talk about the role of litigation. So when you think about other illnesses and people who bring cases against practitioners, it is not that uncommon. And the litigation's usually based upon the person didn't use a standard of care. So I think that's something else that as we advance as a field, because again, we're like the last frontier, that may become more common. And so it's also a protection for the practitioner to practice according to the evidence.
What a well said way to say it, which is so true. So, and then the next point of summary to make sure we got it, could you identify the evidence-based intervention that are most common for mental health substance use disorder and the current barriers to providing it?
Oh, well, you know, we talked about CBT and DBT and ECT. You know, I'm using the initials now because the words are long. We talked about, you know, family partners partnership for prevention and multi-systemic therapy. I would also, you know, one thing we didn't talk about is children and school-based treatment.
Oh,
And
yeah.
one of the things is we should be very skeptical of school-based treatment that doesn't do home visiting and include families. We're doing a lot of money has gone into school-based treatments. And the one thing you don't want to do is do it poorly. So it
Yep.
doesn't benefit anyone. So I just wanted to just wanted to say something about that. The barriers are really not that many practitioners are skilled. We hope more will be as the climate and environment changes. And, the other barrier is how do you get to a highly skilled practitioner who will take your insurance? And, you've talked eloquently about the roll-ups that hopefully will make that easier and make people band together into companies that do the back office for practitioners and that have the kind of clinical supports embedded in the medical record so that people have these decision supports available as they're treating, and also these measurement-based instruments. I think all of that is something we'll see in the months ahead, and I don't think all that too many years from now.
I agree with you. I mean, I've just seen so much just coming out lately. We talked a lot about what the therapist can do in their office. What about how they connect or communicate with the whole care team? What if that therapist or that client is seeing a psychiatrist, or do they have a primary care that's doing their medications? Is there anything about that
Yeah. So I think what we've seen that is newest, and again, I think makes mental health care and addictions a part of whole health, right? Is really what's called collaborative care. It began at the University of Washington. Jürgen Unser was the architect of it, and he did it really focused on depression and diabetes, and that people who had diabetes who got treatment for depression included in their treatment for diabetes did better with their diabetes. And so that became collaborative care. It was, I think, called AIMS was the original research. And that now in 2017, the Center for Medicare and Medicaid, where all what people get paid for in healthcare gets established. What they say, then commercial insurance adopts, right? So they introduce codes for collaborative care. So if you're a primary care clinician, let's say you're, a family practice doc or an internist, you can do treatment within your treatment of that patient. And the way you do it is by having a care manager. Someone, does not have to be licensed, but has to be skilled at understanding, people's life situation and be helpful at helping a person manage their appointments, all of those things. You have a psychiatrist, often a consulting psychiatrist, or even a psychiatric nurse practitioner, who, you can do via telehealth, who consults on that patient, helps develop the treatment plan, then the care manager makes sure it's carried out. And all of that is now billable. There are codes, and everything in healthcare is about the codes. There are codes that can be billed, and I think we need primary care, to adopt this. They have to get enough money to change their workflow, how they do business, have more billing codes. I mean, it's not simple. And a lot of it is being done with grants now that kind of augment the codes. But I think we're seeing pressure to increase the amounts that those codes bring in. And this is another way to deliver services. So that's, I think, another kind of transformative,
Yeah.
change that we're seeing.
And I think all that's great for our therapists that take insurance.
Yes, that's
How do
right.
we, how do we get more to take insurance?
I think your idea, of the roll up and taking insurance because there are companies making it easier for people. Doctors spend most of their money on their back office. They're billing a million different insurance companies, right? It's very
Right.
expensive to do that.
Yeah.
They have,
Right.
special companies they have to contract with, they have staff that, it is not easy. So I think that makes insurance more appealing. I think the other thing are rates. I mean, I think, again, employers have to pressure insurance companies. Employers have to be willing to put more money in it and what they pay insurance companies, who then can pay better rates. It is everyone has a piece of this pie. There is no one villain, right?
Right,
Everyone's
right.
got to make this a priority. And as you said, consumers have to demand it. And
Hmm.
so that will help improve rates. A very interesting piece of work just came out a few weeks ago. Letitia James, the Attorney General in New York State, called 400 practitioners who were on insurance company network rosters. 85% were ghosts. They either didn't
Oh,
exist, the numbers were wrong, or they no longer take insurance, or they don't take new patients. 85% of the
oh,
400 that they called. Now, the one thing we can demand of insurance companies, even if we don't get into the rate discussion, is we have enough automation and technology that you can find a way to keep those networks up to date.
it's
And
gotta be,
they're
right?
not. That is
Right.
like, for me, that's like a bottom line. Then we can discuss rates and employers giving you more money. The other thing, and this is going to be unpopular, Marjorie, a lot of money is being spent on workplace mental health. I think that's nice, but it's not the same as ensuring when your employee needs care that they get the right care. I think
Right.
that's the priority.
Right. And engagement's going to be key on all these new solutions and employers are, using for
And
their
and we
employees.
know, we know from EAP, nobody uses them. I
Yep.
mean, we've known that for years,
For
right?
years,
But
right?
at least, I think because they're being measured about having these things,
Hmm.
that they're doing it. But I think for as an employee, when my husband's depressed and needs treatment, I care about that more than something you're going to do to make the workplace more responsive. Mental health, I'm
Right.
not even sure what it means. So I do think for me, the priority is effective treatment. And, it's not for everybody, and I may not be right. It's, my bias.
Yes, I mean, this is an interesting time in demand is high, right? And people's caseloads are full and they're burnt out because, the cases are challenging and people are
How come
unhappy.
hedge fund people aren't burnt out?
That's a great
Huh?
question.
I'll let it just hang there. I'm just wondering.
They have the stress, they're high stress, right? They're
But they're very
placing
high paid.
they're very high paid, high stress. I'd say us therapists are kind of, in the realm of teachers and nurses, right? Where
Right.
we're
With
bearing a
high
lot.
stress, lower
Yep.
pay.
Yeah.
It's not a good combination. The
And
most stressed people in our country are assembly line workers who have no freedom at all over their schedules.
oh, that's so interesting. It's really, and I think what's also tough about therapy that so many of us we have no control over. We have our client and we can do evidence-based practice work with our client, but they have their whole ecosystem that play
Yes,
into it too, whether it's their
absolutely.
parents or their kids or their siblings or their, that influence all the things. So in
Yes.
that time, you make a difference and then,
The thing that I think we also need to rethink, and it's a whole other topic, is what treatment looks like in terms of the model. So again, you go back to Freud, that's how we think about mental health, still. And so we're still, again, behind closed doors, goes on for a long time, never, or most places other than like Cone Veterans Network and Centerstone and some others, don't say, let's commit to 3 sessions. Let's at the end of 3 sessions use some measurement to see how you're doing. And by the way,
right,
3 sessions is enough for you now. I'm here for you next year or 2 years from now.
right, right,
So I
right.
think that model, because we're in, a demand society. I expect Lyft or Uber to be here in 5 minutes or 1 minute, and they are. So I don't know
So
that
true.
We need to change this whole concept. Demand, the other thing is we hear a lot of demand that doesn't turn into people really going for treatment. They call 988 to chat, let's say, and they are stressed, but they really don't want to engage right now. So, demand means many things, and we have to realize that and think about what needs to be prioritized, what doesn't, how do we handle it? And it isn't what it used to be. Therapy isn't psychoanalysis.
Yeah, it's a really good way to just think about it in that, and you sort of started this out too, by just people might just need a peer, right? You talked about the stuff you're
Yeah.
doing at Columbia. They might
Oh, yeah.
need a coach, and
Yeah.
that doesn't mean for our therapists that's they're going to take our jobs away. It's just that we should be able to focus on the things we want to focus on, learn the evidence-based practice of those
Yeah.
things, and just really hone the craft
Yeah.
there, as
Yeah.
opposed to trying to treat everyone, or be able to have the coaches or the peers do it in between. I think the key is, are
Absolutely.
we but what about, like, why is that important to be able to also use an EHR
Oh,
or
yeah.
share?
Yeah, I mean, we love and we hate technology, right? I love it when it works. I hate it when it doesn't. I'm not very good at it. But I know it is the key to making many things better, including treatment, right? So that if built into my electronic health records are all these reminders or directions or suggestions, that's very helpful. And we're going to see more and more of that, right? Everybody is looking at that. How will artificial intelligence, who will know, it's so when you go to Sloan Kettering, as I understand it, one of the things that happens automatically is they can predict whether you're going to be susceptible to infection because they have all of that data that they have gone through, that gives them a profile. We're going to have the same thing. We do suicide screens, we do safety plans, but ultimately by looking at thousands and thousands of patients and then looking at your specific patient and how they look in that database, you will know who's higher risk, and who isn't. All of that is coming, and it's not far away.
Wow. The future is here, which is a perfect caveat to our title, Therapy Cafe, the future of mental health. So, Linda, our final question is, what is the number one thing that therapists should take away from this discussion?
You better learn your evidence-based practices. It's coming for you.
And you don't, and I think I would add, you don't have to be good at everything.
Right.
Pick the ones, the evidence-based practices that you want to be good at, and
Yeah.
turn away. Or, to your point, I love when you said, don't just say, here's a number. Help those clients
Yeah.
find a referral. If you can create a little referral network, and you can all kind of share with each other, that way you can start specializing out your practice and get better and better. It is
Great
so
idea.
hard to be in private practice. And I mean, I would say the hardest thing for me was every hour seeing something different. You see complicated grief, and then you see someone coming in with, just major anxiety, and then, depression, like just every hour it's an eating disorder. It's ADHD. There's
Exactly.
so much going on. And so
Right.
just specializing it out makes it so much better.
You're really talking about that kind of group practice that you described before, that we're seeing those roll-ups. And then when you have that, you also have a venue for group supervision, for sharing and
Yes.
consulting with each other.
Yes.
So, that is a tremendous support. So those are really the kind of transformative things that I think we're going to see. I
Thank
do.
you. I agree with you. I'm inspired, and I think everybody wins, because nobody goes into the field of mental health if they do not want, like, helping people and
Yeah.
don't want to help make them better. And sometimes it is really hard, and
Yeah.
it's never quite as it is in school. It
Yeah.
never quite
Yeah.
works out, and yeah.
And the other thing, Marjorie, is we are seeing salaries go up, and that's a
Yeah.
good
Yeah.
because it's been people have not been paid. The world is very expensive, and so it's a good thing that we see people being paid better, and
Yes.
we don't want that to stop.
Thank you, Linda, for being our first guest on the new
I'm honored.
season, Therapy Cafe, the future of mental health. Thank you. You are phenomenal, and just keep going out there and keep making things better with all these companies that you're involved with too.
As are you. I'm really honored to be on this podcast and honored to call you friend.
Thanks so much for listening to Therapy Cafe, the future of mental health. For more information and resources regarding today's topic, please take a look at the episode show notes. If you'd like to obtain continuing education as a psychologist, counselor, social worker, or therapist, you can purchase a 1-year subscription to PsycHub's learning platform. Once you're signed up, you'll have access to earn CEs for this and every Therapy Cafe episode. Plus, you'll have access to our existing library of over 100 evidence-based practice continuing education courses created by expert clinicians. Go to psychhub.com/sign up for more information.